The new method of standardization of venous treatment, the VDL system. Well, it is not easy to compare veins. Most of the times we are comparing different conditions, and we cannot have a good comparison among techniques. And trials do not consider patient specificity, and even regulatory agencies are prescribing the same treatment regardless to the specificity of each patient. In Italy, for example, polygonal 3% form is indicated in every great venous vein without any consideration on diameters and so on. The only method of standardization is SEAP, but the same C can be associated to very different veins. And in order to predict the results of the treatment, SEAP is useless. Standardization is not the use of the same concentration, the same fluency, or at least is not only. To standardize, we must start from the beginning. We must compare similar veins, and therefore we need objective tools. Difference among veins can be found on several levels: hemodynamics, patient-related, pathologic anatomy. For instance, sclerotherapy in a great venous vein where only preterminal vein incompetence is present is different from treating a full junctional incompetence. And there are anatomical differences. For instance, the length of the incompetent vein can be very different. And there is not always a relationship between the clinical picture and vein diameter. So we need something different. We need a new tool that improves the definition of the vein in a patient. Diametrometry, or the measurement of every single segment of this venous vein, is unpractical. I'm presenting my method, the Frullini method, the DIF and the VDL system. It's something easy and fast to calculate, objective, standardized, and gives anatomical and hemodynamical data. Is made with the patient standing with the ultrasound measurement without pressure on the probe. We use the valve status, the diameter class, and the length of incompetence. The valve status we can classify in N like normal valves, P for isolated preterminal valve incompetence, T isolated terminal valve incompetence, and D when there is an incompetence of both valves. Then 4 class of diameters, where we have from below 6 to more than 12.1, which is class 4, and length of incompetence. So we can calculate the VDL. So the first part is the valvular status, the second is the class diameter, and the fourth is the length of saphenous vein incompetence. So this could help to predict the outcome. We are now working on a validation of this system, but I think it's very important to have something like this. In conclusion, there is an interest of companies to push for a technological solution of venous insufficiency, but to put every vein together doesn't help to understand which are the patients who can benefit from sclerotherapy only, or those who are better treated with another treatment. And so VDL could help us to better identify those patients where sclerotherapy only could be the first choice.